Thanks. It's a real honor to be here again. I was reflecting on that on the drive up. This is my third year in a row with you all, and it's sort of, and it's also approaching my third anniversary with CMS. So I've kind of come to rely on it as a seasonal event that marks my stay at the agency, at least so far. You know, Claudia is a very hard act to follow. I sort of think I had to do that last year too, or maybe we were just on the same panel. I can't remember. But I liked one of the things she started out by saying, which is we really aren't here just because of health IT. We're here because of what that empowers and enables us to do. And that's actually what Will asked me to talk about today. I'm not going to be talking about our EHR incentive programs or meaningful use. What I'm going to be talking about are all of the things that we have done in just the past year that electronic information, health information, is either needed to do it, it enables us to do it better, or it helps us build upon the future, build the platform for the future and these various innovations. You know, I think CMS is not, the Centers for Medicare and Medicaid Services is not the only payer in the country, that's for sure, but we are the largest. And I think that along with that, there's a fair amount of responsibility, because what we do at our agency does permeate, you know, the country and other payers as well. In the past, though, despite our size, I don't think anyone would have accused us of being particularly agile or of being innovators, for setting the stage and really leading. And I'm hoping that I'm kind of going to blow your minds today and tell you that, you know, people, when I go to conferences now, they come up and they're excited. They're like, whoever thought they'd be excited about what this huge government bureaucratic agency is doing? But there really is excitement now. I know some of you know about a number of the programs I'm going to talk about. I think many of you probably don't, because you're just so busy doing what you do and do so well that you don't have time to kind of do the environmental scan and look at the landscape all the time of what's happening. But the change has been dramatic. It's been swift, it's dramatic. You know, I'll challenge Lori a little bit on what she was saying in Alberta, Canada. We have many, many places that do have that exact kind of dashboard. And in fact, I mean, we have a health plan down in the Inland Empire that's been serving Medicaid beneficiaries for since its inception over a decade ago, and for at least 5 years, and I think probably 8, they've had exactly that kind of dashboard. I think some of you work for plans and other clinics that have that kind of capability too, and we're only going to see that accelerated. So, you know, that time is now in this country. It doesn't have to just be on foreign, not necessarily shores, but soils, I guess, in that case. So I'm going to give an overview, actually, of one of our most recent centers, the Center for Medicare and Medicaid Innovation, and what they've been doing, talk a little bit about some of the challenges that face us all, and then have some time for your questions and comments. One thing I wanted to just share with you, I don't think I've shared before, is we do have a mission statement. All good, you know, bureaucracies have a mission statement. And I just want to call your attention to a couple of words, because it may surprise you if you really parse this out and think about it, what is in the CMS mission. And the words like a constructive force, a trustworthy partner, continual improvement, all of those are embedded very much in the heart of our agency and what we have been doing. I want to assure you that even though we were all sad to have Dr. Berwick leave us last fall, early winter, the work he set, the stage he set, has very much continued under Marilyn Tavener's leadership. One of the very important pieces that has been put into play is the Innovation Center, as I mentioned. And the Innovation has a specific mission that's actually mandated in statute, and it is to identify, test, and evaluate, then scale up innovative ways to deliver and pay for care in ways that can, in fact, impact on the three-part aim of lowering cost and improving care and improving population's health. That center, as you probably know, was appropriated $10 billion in budget. It's to run through 2019. And an interesting thing about that scaling up, which I believe I may have mentioned last year, is that in the past we do demonstrations. CMS has had the authority to do demonstrations for a long time. What we've not had the authority to do is when they've proven successful to scale them up. That requires, in general, that's required another piece of legislation. Not so with all of these models I'm going to talk about today and the things that we've been testing through the Innovation Center. If they work, they can be rolled out nationally. Claudia already drew our attention to the three-part aim, so I won't belabor that except for to say this really is at the heart of everything we are doing and every new program we roll out. It's not enough to just lower cost. It's not even enough just to improve care. We want to improve care and lower cost while improving the health of the nation, and we really must succeed on all of those fronts. We have recognized at CMS that the current status, it cannot continue. We've also recognized that we're part of that. We have been part of the problem in the way that we have paid for care in a fragmented way that rewards individual services rather than the quality of care. And similarly, we want to be part of the solution. But this slide just recognizes that everyone in this room, in fact, all of us in the private, public sectors, are needed to be part of a future system that will make care much more affordable to all of us who need the care, be accessible, and that's accessible not just to the care, but we really believe that we need that accessibility to the information that we've been talking about here today and the interoperability that you all are striving to achieve. That future system that needs to be coordinated and seamless in terms of the care experience for the individuals that are receiving the care, and of high quality. And quality isn't just technical quality. It's about being the right care at the right time that's equitably available and offers a safe experience for the patient. Something that we've been pushing very hard on, and I think we probably have the longest way to go. I think it's been demonstrated with the personal health records. There's a lot of challenges in there. But somewhat analogously, we talk all the time about patients being at the center of care, and yet there are very few systems that I think most of the patients would tell you really where they feel it really is person or family centered. We have a long ways to go there, go in this dimension, I think, in particular, but it's so important that we make it. And then finally, a system that's supportive of clinicians. We were just talking about the clinical summary, and actually my experience with the clinical summary is sort of different than what I'd heard others talk about, and I'll talk about a small practice I know well, where there are 4 physicians all trying to achieve meaningful use, had been using an EMR for some time. The clinical summary was a new thing for them. 2 of those physicians really didn't want to have anything to do with meaningful use, but they did want the money, and they like using an EMR. They just didn't want to have to deal with the constraints of meaningful use. The other 2 were kind of just open to it. They weren't thrilled with it, but their patients in this one clinic, the 2 that were very open to it, started using the clinical summaries. Guess what? They loved it. Their patients loved it. Because when they tended to be fairly complex internal medicine patients, but when they walked out, they actually had something in their hand that said what the doctor instructed, said would be best for them to do, what medications they were on, when they were supposed to come back. The patients of the other 2 doctors that didn't really like anything about this, what did they do with the papers? Threw them in the trash or in the shredder, because, that was sort of what was conveyed. So my point there is we do need to, it's not trying to put those 2 physicians that didn't like meaningful use down. It's saying we do need to make these systems more supportive of clinicians and their workflow, and not be just adding more and more to-dos on an overly booked clinician. The Innovation Center, innovation starts with an I, so the 3 I's strategy just sort of popped up and actually made sense, but it is about ideas, incentives, and improvement. The idea is that you all have, and that we have been soliciting from throughout the country, in fact, throughout the world, to drive development of new models that will help us achieve the three-part aim. We realize there needs to be incentive to test and to deliver on these new care and payment models. So we are working very hard to align payment and clinical practice objectives, which is, as you all know, something that heretofore we've really been lacking. Our payment incentives have simply not been in alignment with the outcomes that we want to see. And by doing so, improving and rapidly spreading the better care. No longer is it okay to take 17 years from innovation to dissemination. We need to make these changes quickly. I doubt you can read all of these things on this slide, but I just wanted to overwhelm you a little bit with the number of initiatives that we've rolled out through the Innovation Center. And let me tell you, this is a partial list. There are many more, and they are coming out almost weekly. Sometimes it feels almost daily. You know, my job at the regional office isn't to be the expert on any one of these, but to be able to be conversant about all of them. And, you know, my middle-aged brain is challenged. It really is at this point, because there have been so many. And part of that is because we need to test a lot of different things. We need to figure out what works, but we also know that it's not one size fits all, that we need to have sort of a menu for various regions in the country to choose from, for different practices that can work in one setting, but maybe, you know, ACOs aren't for everyone, never were expected to be. So we have this transformation continuum of different programs for groups and practices and healthcare providers to choose on which they would like to participate. One thing in this slide happens to be depicted in a way that sort of the arrow points up as there's increased risk. There's also tends to be increased rewards, and that's how these are aligned across that arrow. It's sort of an arrow of both increased accountability and increased risk. But I wanted to draw your attention to the blue box at the bottom, because that is, I don't think it's drawn that well, but I have to use the cleared slide decks, but that's supposed to show you the foundation, the building blocks, the things that are required to enable all of these different programs. And as you'll see, data sharing, learning networks, regional extension centers, align quality standards, these really all have to do with electronic with health information, and we all know that it really needs to be electronic to help in these different care situations, since so much of it does focus on care coordination and the transformation of care. I've tried to break the reforms I'm going to talk about into two big buckets. One is payment system reforms, and the other is delivery system reforms. And my apologies for going over these fairly quickly, but I do want you to just have a sense of what's going on and how large and swift this change has been. So I'm going to touch on each of these briefly that are mentioned on this slide, but I want you to know that behind a lot of these, there are many more projects. Like, I'll talk about dual eligibles, but there's really a suite of dual eligible programs, at least 5 that have come out in this past year. One that I don't believe I have a slide on, but I want to just take a minute and digress on, is the value-based modifier. That's the last item on this slide, and that's a modifier that will be go up against the physician fee schedule. So for every service that's charged under Part B in the physician fee schedule, starting in 2015 for some physicians, and in 2017 for almost, or if not all, physicians, there'll be a modifier. So they're still paid fee for service, but this modifier by statute has to take into account both the quality of care and the resource utilization, that is the efficiency of care. And our first sort of signs of where we're going with that was in the recently released proposed physician fee schedule rules for 2013. Just want to draw your attention to that, because I think it is so important. And that physician fee schedule has a lot more of interest it used to be that, the people that read that were sort of the people that were just concerned about how much of the doc's going to get paid this year and really tracking all of that. Well, if you look at it this year, there's a lot that I think would interest many of you as well. There are details not only for how this value-based modifier will be applied, but also proposals to further align the physician quality reporting system measures with the EHR incentive quality measures, aligning this value-based modifier with the physician quality reporting system as well. Something really novel is that there is a proposal to pay family physicians and other primary care providers for care coordination for patients that were recently discharged, even without face-to-face encounters. It's actually estimated that family physicians could see as much as a 7% increase in the pay they receive under Medicare for this. So very new stuff, that's in this proposed physician fee schedule for 2013. A couple of other things I'm not going to go into any detail about because they aren't through the Innovation Center and they're just on top of our regular fee-for-service payments. When you look at the hospital side, we rolled out a hospital value-based purchasing plan last year, but we have the healthcare acquired conditions, we have hospital readmission reduction program. There is just an amazing amount of movement, not just in these new and innovative models, but actually even tagged onto our existing fee-for-service framework. So just a little bit of background before I start talking about some of the specific ones here. ACOs, we've all been hearing a lot about these, a lot more perhaps than even it made sense at times to hear from. But I did want to just kind of give you an update of where we are here. As you probably know, we really have two different flavors of ACOs at CMS. There's the one that's considered more traditional, and it's called the MSSP up here. It's the Medicare Shared Savings Program. That one that is an ongoing program. We're now accepting applications for startups for January 1 of 2013, or I should say we will start accepting applications in August 1st, and we'll continue to accept applications through September 19th. We've now moved that completely online, the application process, and we also have two groups that have already started up under the MSSP. The first group started up April 1st. There were 27 ACOs that started then. We had two, AppleCare and Premier in California. We just had another 89 ACOs start up under this program on July 1st. There are 5 that were solely in California and one whose service area included California. So that's the more traditional side. Also going into that are the advanced payment model. The advanced payment model the idea behind that was that a lot of folks wanted to participate in the accountable care organizations, but simply didn't have the infrastructure and the experience to feel confident that they could manage it, and especially the startup cost. So they could apply, in fact, to get a set amount as well as monthly money, a certain amount of monthly payment up front in advance of the savings that they expected to generate to help with those infrastructure costs. It was really geared at physician-based practices, some of the rural organizations that would have the most trouble with the startup costs with an ACO. We actually had a couple, we just announced 15 advanced payment models this week, actually, for the July 1st start. And one of those was Golden Life in Sacramento. On the Pioneer side, this was the group, this is a ACO model through our Innovation Center that was really geared towards groups that had been out here really functioning as accountable care organizations to a greater extent, to some extent anyways, already, and knew that they could succeed. So the risk is a little greater, but the reward is greater as well in terms of the shared savings. This was sort of a one-time shot. They applied, and were announced back in December, I believe. We actually had quite a few, 6 of the, I think 32, were here in California. So California continues to sort of lead the stage in this area. Another program that you may not have heard as much about is our bundled payment program, where we're testing the effect of bundling payments for a variety of services that a patient would receive during an episode of care. And we, kind of similar to the ACO, we know that one model doesn't fit all. You know, one size doesn't fit all. We needed to try different things. So we have 4 different models. We've already received the applications on all of these, although the very first one mentioned here, which just covers the acute care hospital services, only closed several months ago, and the other 3 models, we were accepted applications through almost the end of June this year. But you can see on this slide, there's a variety of models. Some of them include the acute care hospitalization plus post-acute care. Now, if you think about health information exchange, how are you going to do that and save money without health information and without that care coordination that is so enabled by it? There was a post-acute care only model, and then there was a slightly variation on the acute hospital stay where it was prospectively paid, but for all of the services that occurred during the inpatient stay, not just the hospital charges. So stay tuned on that. We don't have information yet to release on how many groups are participating and what the interest was. I frankly haven't heard as much interest on this as I've gone around speaking, but I understand that in some regions of the country this has been very appealing, and so we'll see how many actually decided to participate in it. A model I was particularly interested in because of my background, which includes a long stint in rural health care, and my concern that the ACO models in their current form may not really translate that well in a lot of rural environments, is the Comprehensive Primary Care Initiative. Unfortunately, California is not one of the market areas for this, but I still think it's important that you know it's occurring. It is a multi-payer initiative that works at fostering collaboration between the public and private healthcare payers in order to strengthen primary care. And what we did basically is we went out, we opened our hand, we said this is what we're going to do in terms of, this is what we're going to give in terms of a management fee basically to practices, how much we're going to pay them up front, how much we're going to pay them per month per member, and then how we're going to shift them over time to a shared savings in more of a capitated model in order to better support primary care functions. And actually we really expect to enhance the pay to primary care while improving health care through this model. So we went out to the payer community, we said what we were going to do, and we invited them to apply to participate with us. We reviewed all of those applications back in the winter, and then based on the strength of the applications as well as having a critical mass in particular market areas, we chose 7 market areas in which to roll this out. A few of them are statewide in Arkansas, Colorado, Oregon, and New Jersey, and a few are regional. Right now, we're soliciting practices. We want to get about 75 primary care practices in each of those market areas to participate. And actually, those applications are due by 5 p.m. today, Eastern time, so 2 p.m. here. All really new, builds upon the medical home model and our multi-payer advanced initiative, but a slight variation of it, and I think one that we'll learn a great deal from as time goes on. And as I said, I was quite disappointed as were many people, that California it was not among those that participated. You know, the dual eligibles, those that are Medicare and Medicaid beneficiaries, are a population so in need of better care coordination and also a place where, frankly, we could save an enormous amount of money with improved care. They represent about 9% of our combined Medicare and Medicaid population, but almost about 30% of our expenditures. And that means that's about $300 million a year. So the goal in our dual eligible suite is to improve the quality and cost effectiveness of the care that they receive. And the state demonstration is something you probably have heard of, since California is one of the sites that was selected. We awarded contracts to states for design of models. The 15 states have received those contracts. And in California, I am not an expert on this. We probably have some people who can say more about it than I do. But the idea is that they will be providing care for the dual eligible through integrated delivery systems. And this will include all their medical services as well as long-term support and services and coordination with or care for the behavioral health needs. The service areas in California, initially it was LA County, Orange County, San Diego, and San Mateo, but there's currently discussions, and I hear varying reports as to whether it's been firmly decided, the expansion counties, what other counties that'll be operated in, but it certainly will go beyond those 4 counties at some point. And that's just one, as I mentioned, there's a suite of reforms, and that's just one of them. Now, those are all programs that have really focused more on payment. I wanted to talk real quickly about the delivery side, because that was something else that was mentioned in the question and answers with Claudia is, are we really ready? Do we have the capabilities to really provide the kind of care that could be enabled and enhanced through improved health information technology? And I'm not going to say we're there yet. There are certainly many systems, I think some of whom we're going to hear from later this morning, that I think are doing an amazing job with health information and using that to progress with clinical care. But we do have a number of activities that we've been involved in at CMS on this side as well, in addition to the things that I've already talked about. The Partnership for Patients, how many of you have pledged to the partnership? Anybody? How many people have heard of the Partnership for Patients? Okay, well, I mean, again, it's not, I realize you all are just busy doing your work, and this is sort of outside your daily realm. But the Partnership for Patients is a nationwide effort that was launched over a year ago now, basically to stamp out harm that's done to patients through healthcare. There are 2 major goals. One is a 40% reduction in preventing hospital-acquired conditions, and the other is a 20% reduction in 30-day readmissions. These are all designed to be, we expect to meet those goals in the 3 years of the program and translate to just an enormous amount of morbidity and mortality that's averted, 1.8 million fewer injuries, 60,000 lives saved, but also very large sums of money that can be saved by doing this well. We're now up, this slide is dated, I think we have about 3,800 hospitals that have pledged, and these hospitals are doing things. They aren't just pledging, and part of that's because there are now incentives through our hospital readmission reduction program, through the fact that they don't get paid additionally when there are hospital-acquired conditions. There's some real teeth to this. In fact, hospitals are now up to, it's getting close to 7 to 8% of their Medicare dollars are at risk based on quality, and there isn't a hospital in the country that is accepting Medicare that can afford to walk away from a 7 to 8% of those dollars. So there's some real teeth to this. In addition, for this particular program, there's about $1 billion of funding. Half of that, approximately half of it, is going to a community-based care transition program, where that's for community-based organizations who will partner with hospitals to reduce hospital readmissions. That is, applications are being accepted on a rolling basis. We still have, I think, a couple $100 million of that money, those monies available. The next review panel is going to meet September 20th. So if anyone is with the hospitals, with a community-based organization that might be interested in that, they have until September 3rd to apply. And a lot more information is on our innovations.cms.gov website, and I'll give you that email again later, or you have it on your flash drive. So $500 million for that project. There's also about a hospital engagement network, which is all about making care safer, and we now have funded hospital engagement networks that are functioning in all the states. We awarded $218 million to 26 organizations that will help hospital networks across the country make patients safer. So there's some real dollars tied to this otherwise voluntary program, and I think that's why we've seen a lot of excitement and uptake by the hospitals. Million Hearts campaign is another one that is a cross-agency across the Department of Health and Human Services, and the goal of this one is to prevent 1 million heart attacks and strokes over the next 5 years, primarily by focusing on what we call the ABCs, which is aspirin, blood pressure control, and cholesterol control. Big focus again on health IT and the use of electronic health records to improve the care and enable quality improvement. This has two sides to it, the clinical side, the clinical prevention, but also working with communities to reduce the need for treatment by preventing tobacco use in the first place, and improving nutrition as well. This is another one. If you're just sort of interested in this or maybe been affected by it yourself, we welcome you to go on to the website, learn more about it, and pledge. There will be more that you'll see about this. It's still unrolling and changing. We have a toolkit right now that's more of a speaker's toolkit, I feel, but we're working on a clinician's toolkit to help clinicians in their busy lives implement some of the things that need to be done and can be done fairly readily with electronic health records to improve the workflow in offices so that they actually do a much better job than they currently are at addressing those ABCs. You know, smoking cessation help is still only offered to about 1/4 of smokers who want to quit smoking. And it's not because docs don't care. It's really about how do we work this into the flow of a busy clinic so that we can enable physicians and other practitioners to take care of these issues. Do I have any innovation advisors in the room? Often there's one I see Will's pointing to say, we got a bunch of innovation advisors, but this is a program through our Innovation Center to get more folks out there that have the ability to institute new models in their home settings, whatever their clinic or organization community might be, and to deepen the skill sets. We announced the first group of 73 advisors last December. We hope to train a couple hundred over the course of the first year or two. It's a one-year program where they actually meet together a few times. I think it ended up being 3 times together for a couple of days, but also working on projects with mentors and within groups over the year of the program. So, you know, we're really trying to spread and disseminate knowledge and get other folks excited. What I've heard as feedback from that is they really had great lineups for the instructional piece of this, the more didactic, but also have come together as groups to really do some wonderful stuff during the first 8 months or so of that program. If you're interested in something like this, that we do expect another round at some time this fall, so keep your antennas up and think about applying. We actually had 5 of the 73 in that first round are from California, real interesting, diverse group of projects that they've taken on. And everything from palliative care to sort of more standard care transition models. Something you may have heard about lately, because it's been got a little bit more media coverage, is the Healthcare Innovation Challenge. These are large grants that were designed to identify a host of different delivery and payment model reforms that might help us achieve the 3-part aim. We solicited applications and were frankly completely overwhelmed by the volume. I should say the Innovation Advisors Program, which we thought we'd get about 200 total, we had over 900 applicants for the first round. For the Healthcare Innovation Awards, which we had about $1 billion to fund these various models that would be selected, and they had certain attributes they had to meet. We had about 3,000 applications, which was, I mean, we knew we would get a lot, but we had no idea that we were going to receive 3,000 applications. There are 107 awardees, and they covered all the states, including Puerto Rico and the District of Columbia. We made them in 2 batches. The first was announced May 18th, or May 8th, and the last one was just announced June 15th. 17 of those 107 have a presence in California, meaning they are multi-state, including California. 10 of them are really operating exclusively in California. They're a very diverse set of projects, and I'll just mention a couple, not because they're necessarily the stellar ones, but because they represent the diversity in size and intent. Palliative Care Consultants in Santa Barbara was one of the grantees. It was a $4.2 million award. They're expected to save $3.2 million in their program by basically implementing a physician quick response service to provide home healthcare services to frail elderly who are in crisis and probably nearing the end of life. These rapid response teams will go out to their homes in order to both delay to reduce the delay in care that they often experience, especially if they have to go in through the emergency department to a hospital when they don't even really want hospital care in the first place. They just want care, and they'd rather it be at home, but also to lower exposure to those hospital-related incidents that almost invariably occur with elderly folks who are really at the end of life and wanting to just be comfortable and be in the most humane environment they can. On the other side, one of the larger grants was the Pacific Business Group on Health received a $19 million award. They're expected to save $25 million. They're going to be working in Arizona and California with Medicare and dual eligibles who have multiple chronic diseases, and really pushing the envelope on better care management and coordination of care to reduce the ER visits, hospitalizations, and the complications therein. So that's just, I'm sorry for the whirlwind. I've talked about a lot of things, but one thing I do want to leave you with is that it's not just that we're doing a lot more. It's also the way in which we're doing it. I don't think you would have seen our agency be able to or have the capability of rolling out this number of programs, much less doing it well, without a change in our attitude and the way we work. And part of that is that we're rapid cycling through these. For a real quick example, the Healthcare Innovation Awards, those 107 fairly large awards I just talked about, last week we sent them the template for their operational, that they need to submit for their operational plan. Next week we expect to start getting those. We have the teams ready. We will be evaluating them the day they can't come in. We will be rolling those evaluations and the recommendations back out in an iterative process and tying that up as probably within a month or two. It's sort of unheard of. In the past, it would take us months to get the operational plan template out to you, sorry to say, but that's just not the way it's continuing, the way we're continuing to work. We do continue to seek innovation ideas. I will cut to the end here so you'll have some of those websites. We continue to seek your ideas because we realize we need your partnership, we need your ideas. We're all in this together. It's a journey that none of us could do alone, none of us would want to do alone. So we're very, very happy and grateful for the work that you do. I'm going to leave you with these resource URLs if you're interested in those, and I think we have time for a couple questions. Thank you.
Are you ready?
Here we go.
Hi, my name is Barry Lotion, and just a general question about the number of different programs that CMS has relative to delivering high quality patient care and the payment systems and the payment reform programs that you talked about. There is a huge number of programs. And it's just my impression is you almost need a PhD in whether it's relative to payment reform or whether it's relative to the different clinical high quality programs that are being initiated and tried by CMS. My question is, do you anticipate, or is there any planning going on right now at CMS relative to the consolidation of some of these programs, and what the plan is for actually taking some of the, what we've learned, doing the 80-20 rule, where 20% of these programs are successful, and unfortunately laying the other 80% stay in the background, to wherein we are actually going to get some great benefit, tremendous benefit from those 20% of those programs that are successful. And is there any planning going on right now relative to the consolidation and the review of these programs?
Yes and no. I mean, in terms of consolidating, we're not planning to consolidate them right now because these are all very much in a testing mode. I think if you look at, you kind of have to look at, if you're a clinician, if you're a provider out there, you have to think about what your needs are, what your capabilities are. And I think even though there are a number of different, on that transformation continuum, there may be 6 or 7 different models to choose from. For most providers, there's really only 1 or 2 that are going to fit their needs because we are very much in a test mode. I mean, that's what the Innovation Center was funded to do over a relatively short lifespan. So while we're not looking at consolidating those, we are harmonizing things like the quality reporting between them, the metrics we're looking at. In terms of the question, though, about sort of future, what we'll do, very much so, we'll be looking at evaluating those. The ones that work get scaled up. The ones that don't are, unless they can be sort of reinvented and taken a different way, will not. Do I think that we're going to end up with 20 different models that we're working simultaneously on? No, I think that you're right. We're going to see some of these fall off. But we don't have enough information. We don't know enough to know that we shouldn't even start down some of these paths. We need to quickly gain that experience and understanding of them.
Next part of that question is relative to the Innovation Center and the Innovation Program. There are you mentioned that there are, almost a new innovation grant going to a company, a startup almost every day. Is the government or a CMS or someone going to help commercialize some of these innovations, some of these startups, so that they can sustain themselves beyond the grant money that they're getting from the innovation program? And is that being incorporated in terms of the planning relative to them actually getting funded, in terms of their plan?
Well, I'm not sure that we're talking about the same thing. When you talk about innovation grants and when I do, we are not giving grants to startup companies. That's not what we do. We are putting out models of care delivery for existing healthcare organizations to apply to, and we really stay away. We stay vendor agnostic. We don't get into commercialization really of any product at CMS. So that's not a role you'll be seeing. We don't play that now, and I don't foresee us playing that role at CMS in the future. And I don't want to speak for the other federal agencies, but in general, we have, the government has to stay vendor agnostic and stay commercial free.
Okay, thank you.
And I will be here most of the rest of the day, so feel free. I'm sorry I wasn't with you yesterday, but feel free to come up to me at any time during the day.
Elsa?
Thank you. Sorry. Thank you, Betsy, so much for such a full purview. I think this could be all day, probably. There were 2 things I'd love to go back to. One was, I was so glad to hear you two were sorry about this, but you mentioned the comprehensive primary care initiative that's over and done with, that California's not a part of. If you ever hear any inkling of that coming back again, please know that on Wednesday night, before this conference began, we had a community practice meeting for all the grantees from Cali Connect, so all the HIEs in the room. And we were asked to think of current topics that are burning issues for us, and we did breakout sessions on them. And the second topic mentioned, and the largest table gathered, was about getting all the payers to the table.
Yeah.
And we started that because we have such difficulty incenting our individual physicians, and frankly even FQHCs to come to the table who aren't already part of an ACO. And thank you so much for all the ACO effort. If there's any way we could ever come and join that, would love, love, love to do that. And you mentioned also dual eligibles. We would, and that the areas for that aren't quite finished being figured out yet. We'd love to offer Fresno or Stanislaus County in the Central Valley, which has a slightly different population, for part of that, and I will talk to you about that later.
Okay, and for anyone else interested in that, that's really, you know, the state is completely the lead on that. They have a website up and running. I don't know if we have, I'm looking over at Lisa, but I don't know if we have anyone in the audience that knows more about the state dual eligible program.
I know we have several dual eligible pilot programs, right, Pam?
But
And
we
they're
can certainly
already
get you in
established.
contact with it. Thank you.
Yeah.
Hi, Betsy. Steve Murphy. Wondering if you could talk a little bit about how CMS is using HIE or wants to. Your counterparts at VA and DOD and Social Security have been very involved in moving data. So I'd be interested to hear whether or not CMS wants to enter this fray.
Well, you know, I would say we've already entered it. Remember, our job, our mission really is both to pay for claims, but also to understand how best to help move our delivery system forward and improve the care that's delivered by or received by our beneficiaries. So we really look to Claudia and her colleagues at ONC as the leads around health IT. But as I tried to say early on, you know, it's not just having an EHR in the office that we're interested in. It really, whatever innovation we choose to talk about, every single one of those is advanced by health information exchange and interoperability. And if you look at the criteria on which we judged the applicants for the Comprehensive Primary Care Initiative, or almost any of the programs I mentioned today, their use of electronic health information, the ability for the work that they were proposing that it would advance the exchange of that information was a criteria on which they were judged. So we feel, I mean, it's a foundational building block of where we want to go in terms of the three-part aim. We have to have not only electronic health information, but the exchange to achieve what we want to achieve. So it's foundational. Is it our bread and butter and what we're going to have a whole host of people working directly on in our agency? Probably not, although we have some people who are very knowledgeable in it, because again, we have to focus on the clinical delivery of services, but that is very dependent on, in the future, on health information exchange. So we support the work you do very broadly.
Thank you.
Thanks.
All right. Will you thank me and will you join me in thanking Betsy? Thank you.